So thank you so much, and hello everybody. And special thank you to the families who organized this wonderful meeting, also those who are connected online. And I hope that those who are here and visited the city from other countries and other cities have some time also to enjoy Barcelona and have some free time, not only being focused on the conference. So I would like to present the Grinscale, which is a project in which we have been working for the last year and a half, more or less. And I will start with very simple concepts and then moving slowly to the green scale. So what is a scale in medicine? A health scale in general are tools aiming to measure a variety of conditions or symptoms that are usually difficult to measure in a quantitative manner. There are some scales that are really very easy, like this one, pain scale, where a 0 is no pain and 10 is the worst pain possible. And then we have all different numbers in between. So that's really very simple. But then when we have to go to the brain and quantify the functions of the brain, it becomes a little bit more complicated because we have to assess different aspects, neurodevelopment, intelligence, motor function, behavior, and some other functions that are what characterize our brain. So if we focus on neurodevelopment, which is the process of gaining different abilities through the first stages of life, so starting to walk, to talk, to think in a logical way, and all these functions, we have some standardized scales, such as the Bailey scale, but here we have the limitation that we can go only up to 24 months, and there are some weak points of this scale, like motor function maybe is not evaluated properly. If we have to evaluate the intelligence quotient, it has also some limitations. We can do that only from 6 years on, and it's applicable according to neurodevelopmental level. So difficulties, sometimes it is not applicable because the questions are too difficult and are not adapted to what the child can do. So how can we evaluate cerebral functions in patients with neurological diseases, not only in healthy population, but when a neurological disease is happening? We have this very standard and very useful test and very well known for the medical community, which is the Vineland scale. That is a very useful scale because it may be applied from birth to 90 years of age, maybe 100 also, and help assess adaptive behavior in individuals with different types of difficulties, intellectual disabilities, even autism, or even in dementias. And it assesses multiple aspects and communication, daily living skills, socialization, motor skills, and others. But on why don't we apply directly Vineland to our green patients? This could be very helpful, and we did that, for instance, and in addition to other scales in our clinical trial that Dr. Natalia Julia will present tomorrow. Because we have had the opportunity of visiting and seeing many patients in the last few years here in Barcelona, so we gained some experience in green patients, and we thought that it could be very useful to quantify the clinical symptoms in green patients. Thanks mostly to the experience that we have in the clinical trial with Elserine, because we have also been contacted by many doctors from many places with specific questions about specific symptoms of our patients, and also because we have had the opportunity in our international patients consultations of visiting many patients, not only from Spain, but also from many other places. So what have we learned from this experience in the last few years is that green patients have particularities that are not accurately detected by the conventional scales that I mentioned, like Vineland, Bailey or other conventional standardized tests. Also that there is a very marked spectrum of clinical involvement in these patients, from very mild form to very severe forms. So it's difficult to integrate into a single test that could be useful to evaluate all kind of patients. And also because during the clinical trial with L-serine, we have detected improvements, most of all reported by parents, by caregivers, educators, that are not detected in those tests that I show you. So for instance, we detected that it is something that improves, and that for sure children have this capacity, but it's enhanced with this treatment that we perform, the ability to imitate, or the ability of making jokes or understanding the figure meaning, the double meaning of things. They also increase the complexity of the games. And these changes that can be important for the patient and for the families are not properly detected in these scales. Like we also detected an increase in the complexity of drawing. You will see that in more detail tomorrow with the presentation of the clinical trial, or the complexity of the written line. It's also something that improves a lot in some patients, and it is not very properly detected. So how a specific scale for GRIN-related disorders can be elaborated. There are several examples for various rare genetic diseases in which specific scales have been already developed. Rett syndrome, in Angelman syndrome. We have an example that I will show you right now in brain iron accumulation diseases. We are now participating also in the development of a scale for childhood Parkinsonism. So this is something that has been developed before in a constellation of different genetic diseases. So it is, we already have in the medical community this experience. So this is an example. It's our colleague Alejandra Darling here in the house in St. Juan de Deo Hospital developed a scale for a rare disease where iron accumulates in the brain, is pantothenate kinase deficiency, and she evaluated different domains. These are some of them: cognition, speech, handwriting, feeding, then motor function, with very simple questions. And this is an example. This is another example of the evaluation of motor function in Rett syndrome. And here you can see, this is in Spanish, but I will translate it for you. It was performed initially in 60 participants with 6 subscales and 25 items in total. And it is just very specific for Rett, is very easy, is accessible to everyone. You don't need a specific training to do that. It takes 40 minutes to do that, and has also like a training, a support, like a tutorial to apply that. So a scale is developed as a scientific project, so you have to establish objectives, methods, stages of development, and that's what we did. And we presented that to the Spanish Patient Association of Brain Disorders, and we were very lucky, and we are very grateful that they were able to fund this project. And so we created a team to work on that. But most of all, the persons who have been more involved are, first of all, Natalia Julia, who is a child and adult neurologist and who has also a broad experience in GRIN disorders. And then Rosana Marie, who is a neuropsychologist and speech therapist, who also worked in close collaboration with Natalia to start this project. Not only pediatric and adult neurologists, but also physiotherapists, neuropsychologists, patients and families for sure, and mathematicians are important for the development of the scale, because they have to calculate the statistics and to know if the items that we are like introducing in the scale are feasible. So there are some specific mathematics aspects that are important in medical scales, and there are some mathematicians that are specialized in medical scales. And we did that through the Spanish Ministry of Science and two mathematicians who are experts in the development of the scales. So that's what we did, the different stages. We first did an extensive review of the medical literature, and we elaborated a first draft. We shared that with the families here in Spain for the validation of some of the items, and they suggested to include some things that we didn't consider at the beginning. We submit that to the ethics committee of our hospital, and then we started to develop the scale. We discussed with the expert mathematicians, and we came out with two different scales: a severity scale that is going to be used by doctors only, just to give a severity, a score that is like mild, moderate, or severe. And then the GRIN scale that aims to be a friendly scale that could be used by all kinds of specialists and even by parents. So first of all, we did an extensive review of the medical literature, searching for what already exists in similar disorders and searching for all existing scales to evaluate specific functions of the brain: development, cognition, behavior, motor skills, and so on. And it took like some time. And after that, we focus on what functions are important to assess in GRIN patients according to the literature, what has been described, according to our experience also with many patients so far. So we came up with all these items that we think that are important to be evaluated: attention, memory, language, executive functions. Executive functions are those who help us to focus on a task, start a planification of something and be perseverant and so on. So behavior, motor functions, all these items we thought that could be really very interesting to be considered in the scale, but these items should be age-related because for sure these functions change over time. So we should be able to assess patients of any age, but not only neurological functions, but other non-neurological functions, as you will see, and utilized by different specialists. So these were more or less our goals to develop the GRIN scale. And we started with our first draft, and we came out with all these functions, and the numbers are the questions that are related to every function. So 11 questions for food-related things, like communication and relationship, 13 items, 13 questions. For gross motor skills were the most, we have many questions, and this was based on parents' report in the last 3 months. So these items, before going on, so we discussed again with the expert mathematicians, and we did some changes from our original first draft, aimed to simplify things, but because this is too complex, it's finally difficult to implement. And then also because we need some statistics variants, and they modify a little bit in order to be statistically analyzed. So finally, we had this, I will give you just some examples. For the item feeding, we had 10 different questions, and these questions can be evaluated as knows that the child, the patient is not doing that, or that. Like, for instance, is he or she able of eating crushed foods like pads, or able of eating with fingers, able of eating alone? You see that these questions go in an increasing complexity. So the first question is very simple, and then the last question is really the top of the acquisition of the function. And it could be the score could be no, he's not able or she's not able at all, or is just starting, or is partially acquired, or is totally acquired. And we have also here this column to say it is not applicable because of the age of the child, or because the question was not made. So this is like the whole structure for all the functions that we are assessing. Here we have another a function like dressing up. So you see here the degree of complexity. He helps to get him or her dress or an undress, is able to remove his shoes, gets dressed alone, like the most accomplished function. And then we go again and again to all these functions, not only food and dressing that we already saw, but to other functions like gross motor skills, where we have 20 questions. This is the more complex. And we go again to the very, very simple, keeps head up, to takes very small steps to walks downstairs alone or walks alone, or is able to use a bicycle and so on. So, and we give all the scores to every function. We also included non-neurological functions because we know that these symptoms are irrelevant in GRIN patients, like gastrointestinal symptoms. And we have here 10 questions, like constipation, abdominal pain, or others. And we also include autonomic symptoms. So those symptoms that are related to the autonomic nervous system, which are also important, and the symptoms are frequent in GRIN patients, such as, well, intolerance to heat or cold, excessive sweating, the neurostorms, and on all that. So we wanted to collect really everything. So what we can say is that it seems to be like an easy scale that measures non-neurological symptoms as well, that could be used by families and various professionals. It would allow us to assign a certain score to each patient and also to each function, and could be useful for assessing response to treatments in different areas. What are the next steps? So we started that in a pilot test in 20 patients in Spain. We have to complete up to 60 patients in order to be validated, in order to acquire the statistic significance that has been recommended by the mathematicians. And then we would like to do, if we have funding for that, an English translation, and then the whole process starts again, because you can validate a scale in a single language. Then you have, if you have to need to translate that in, I don't know, in 3, 4 more other languages, you have to start the process again and do all the steps that I mentioned before in order to validate in every language. I think that at least English would be very interesting in order that this could be accessible to many patients. In that case, what we should do, we need to do, is to share that with professionals from all over the world, just to try to validate the scale. Here we are doing that only with the Spanish professionals, but here, yes, it will be like a translation to many other professionals and countries. So I just told you about the Grinscale for everybody. Everybody can use it. And just a couple of words about the severity scale. We did that just for doctors and assessing some domains with more technical questions: language, gross motor function, epilepsy, movement disorders, and behavioral problems. That's what we assess in this scale. And this is an example just of epilepsy, the frequency of seizures, and you have to give a score on that: intensity and duration, risk of falling or injury during seizures, number of anti-epileptic drugs, interference of epilepsy medication, and so on. And then we have a mathematical formula to assess the score for every item. And finally, we will have a score of severity for every patient that can be also very useful, and can be useful because you have a classification. And as far as when we have a real natural history study, we will be able, according to this classification, to know maybe what is the evolution of a particular group of patients. So the patients with mild classification, how are they evolving over time? Or the patients with moderate, maybe this is something that can be used for that, or also for the response to treatments in clinical trials. That depends on what are the main objectives of the clinical trial. So as the final messages, I hope you have seen that scales are needed to measure disease expression. And in rare diseases, the development of the scales can be especially complex because there are many items to be evaluated, even more in neurodevelopmental disorders, because the child is gaining abilities, and everything is changing over time, sometimes very quickly. I think that it's interesting to have own scales in specific pathologies. It is true that neurodevelopmental disorders have a core of common symptoms, and maybe in the future we will use like a core for all neurodevelopmental diseases and then like additional particularities for every disease. We need an expert multidisciplinary team that is very important. We need a validation process, and I hope that it could be useful to classify and evaluate the response to treatments. This was all thanks to the Spanish Association of GRIN disorders, and they deserve that, and we could do that because of them, and especially Natalia and Rosana. And just I want to say a couple of words, and this is Sandra Silva who asked me to do that, about a project that we are starting in or leading in our hospital, which is a brain metabolism project. Because, well, in our group comes from brain metabolism, from neurometabolism. This is our background. It is somehow a little bit atypical because most doctors in charge of GRIN-related disorders come from the epilepsy field, but we come from metabolism. That was like that because we are really involved in neurotransmission and in inborn errors of neurotransmitters, but then we included receptor disorders also in this broad category, and that's why we took care of that, and also because we developed a metabolic treatment for GRIN-related diseases. So in fact, brain metabolism, we want to create this network because it is a meeting point. So no matter the disease, you can explain or try to define it in a chemical way, because either energy or lipids or different cell biology processes will be like involved and affected. And this is what we started. So we want to create like a group between different European reference networks for rare diseases. So in the brain, for rare diseases of the brain, we have now like 4 different networks. The MetaBRN, which is the network for metabolic disorders, the network for rare neurological diseases, the network for epilepsies, and the network for neurodevelopmental disorders. But there is an important overlap here. And well, for instance, GRIN disorders are here in Epicare, but could be here. And from our point of view, could be also here. So this is something that we started already this year in July with the organization of a first program and inviting many doctors from different specialties to be like the approach in diseases focused on metabolism. And this is something that we want to develop more and more, and probably GRIN-related diseases will be one of our pilot group of disorders to start, because we have to combine the efforts of the epilepsy community, the neurodevelopmental community, all the experience on chemistry, biochemistry, neurotransmission, and so on that we have in our team. So that's a project that it's complex, but I hope that could go on. And also thank you to Sandra, who is working a lot on that, and the help of the patients. We had actually a patient roundtable there to discuss about some problems that are related to all this complex world. So with that, this is my last slide, and thank you so much for your attention. And I think that the floor is now for the next speaker.